Hello, everyone, and good afternoon. Thank you so much for joining Unshamed Kentucky today in our webinar, Adverse Childhood Experiences in Opioid Use Disorder. So going through our agenda today, we're going to do a little bit of some housekeeping, give a little intro about our Unshamed Kentucky campaign, give an overview of today's webinar, give an introduction to our amazing panelists we have today, and then our panelist has an amazing discussion prepped for us all today. And then we'll leave out the opening for Q&A. This webinar will be recorded and made available on the Unshamed Kentucky Facebook and YouTube pages. All attendees will be muted. Please use the Q&A button at the top of your screen to ask questions. You may also drop your questions in the chat if you prefer that. To adjust your view and see all speakers and panelists, click View at the top of your screen and then select Speaker or Gallery. And for today, we do have access to closed captioning. You click More, select Language and Speech, and choose Turn on Live Captions. We also have our live ASL interpreter today. So a little bit about our campaign. So Unshamed Kentucky is an evidence-based behavior change intervention aimed to reduce the addiction-related stigma held by Kentuckians. The campaign is delivered by Shatterproof, a national nonprofit committed to ending the addiction crisis in the United States. In close partnership with the Kentucky Opioid Response Effort Team, or CORE. This project is supported by CORE through the Substance Abuse and Mental Health Services Administration. So for today's webinar, we will have an insightful Today's webinar will be insightful by exploring the connection between adverse childhood experiences and opioid use disorder. In this engaging session, we'll delve into the latest research on how childhood trauma can impact substance use and discuss trauma-informed approaches to prevention, intervention, and treatment. So our moderator today is going to be Sophie Dry. Sophie is a 33-year-old woman of trans experience from Louisville, Kentucky, now residing in Lexington. She works at Voices of Hope under the KIPRC grant, focusing on linking the BIPOC community to quality care. In this role, Sophie is on the front lines fighting stigma and spreading accurate information about substance use disorder. Her work is informed by personal experience, as she has been in recovery for 3 years. In her spare time, Sophie enjoys playing PS5 and spending time with her puppy, Brody. Miriam Silman is an executive advisor at the Kentucky Department for Behavioral Health, Development, and Intellectual Disabilities, working to create a trauma-informed, healing-centered, resilience-oriented system of service, delivery, and workforce support across the Cabinet for Health and Family Services and the Commonwealth. She has worked as a clinician, researcher, and trainer focusing on trauma and resilience for more than 35 years, including at Mountain Comprehensive Care Center, the University of Kentucky Department of Psychiatry, and the University of Kentucky Center on Trauma in Children. Then we have Hannah Edlin. Hannah is the Director of Policy and Strategic Initiatives at Kentucky Youth Advocates, where she leads the Bloom Initiative's fight against adverse childhood experiences and specializes in K-12 policy. Hannah earned her master's in education and is currently a PhD student at the University of Kentucky. Hannah is a children's author and a former Miss Kentucky. So everyone, just give our panelists and moderator a digital round of applause. They have an amazing conversation for today, and I will pass it over to our moderator, Sophie.
Hello, everyone. I guess we're just going to go ahead and get started with question number 1. What are adverse childhood experiences?
I can hop in on this one. So the concept of adverse childhood experiences, it really emerged from the work of Dr. Vincent Folletti in the mid 1980s, who, while working at the Kaiser Obesity Clinic, he noticed a high dropout rate amongst many of his successful patients. And he found that many of those patients had histories of childhood abuse. Folletti's initial study just had roughly under 300 cases, but that study showed a link between early adversity and obesity. And this study in the 80s propelled the desire to examine this relationship further, which led to a large scale study examining childhood adversity and adverse health outcomes with the CDC and Kaiser Permanente, with a sample size of over 17,000 adults. The goal of the study was really to better understand factors and behaviors that influence disease, disability, and early death. And one of the major findings from that study showed that ACEs, adverse childhood experiences, have a significant impact on physical, mental, and overall health and well being. The concept of ACEs is defined in that study as traumatic events that occur in a person's life before the age of 18. And the study, it identified 10 types of ACEs that were categorized within the areas of abuse, neglect, and household function. And each of those variables are physical abuse, physical neglect, emotional abuse, emotional neglect, sexual abuse, and then items of household dysfunction, including parents divorced or separated, witnessing domestic violence in the home, substance use in the home, mental illness, as well as experiencing a family incarcerated loved one. And then the findings from that study really showed that the number of ACEs, or adverse childhood experiences, increase the risk for developing different types of health issues, things like greater risk for smoking as an adult, liver disease, financial problems, greater risk for attempting suicide, risky behaviors such as alcohol, as well as depression, teen pregnancy, and heart disease. And we know that the study tells us that the more the ACEs, the greater risk. So there's a dose response there that exists. So, for example, if you have 3 of the 10 ACEs, the study showed you were twice as likely to have heart disease. And I know my colleagues on this call have some more thoughts around ACEs, but one thing that I want you to leave knowing is that understanding ACEs, it really creates the opportunity for us to not only measure risk, but better transform policy and practice for prevention. And our ACEs are not our destiny, they are a measure of risk and help us support communities and families. Miriam, I'll give it to you to add on.
Sure. So, and the thing about the ACEs study is that we really should see that as the beginning of this powerful understanding of all of the factors and the contextual factors that go into creating who we are and how we're able to interact with the world. And so, as Hannah said, that original ACEs study looked at things that were happening within the family and within the household. But we all know from our experience from looking around the world, particularly from I'm getting old, so I think the last few years really feels like it's given us some lessons in this area, that there is a lot that we are all grappling with, and that all of those things impact us in different ways. And so what came after the ACEs study is really, really important. And that was the beginning of this explosion of literature. So that first sample, even though it was very large, 17,000 plus people, it was primarily white, it was primarily middle class, it was primarily college educated. And so what was, I think, astonishing and grabbed people was that would not necessarily be a population of people you would consider, quote unquote, at high risk. And yet it turned out that they did have a number of adversities and a number of things going on. As the research has been replicated and extended to other populations, particularly, I think, the work of the Philadelphia ACEs project, we've really seen that in different kinds of communities, and communities of color, and communities that have more economic challenges. We see even higher rates. And so that helps us to understand, as Hannah said, where we need to be really targeting our efforts for prevention and also then for remedy and repair. And then out of that original ACEs study, we started to think, well, what about looking at not only what happens within the household, but what's happening within the community? And so then we started to think about this idea of the pair of ACEs and recognize that what's happening in the soil of a tree, for example, really influences how well that tree flourishes and thrives. And I'm going to drop something in the chat in just a minute that shares a diagram of the pair of ACEs from the Center for Community Resilience. And then we thought, well, it's not just what's happening right in the community, but what about the literal climate and environment? So that introduced a third area of adversity that we may have to deal with. And certainly, I think Hurricane Katrina is a really incredible example of this, that we know that people who were already suffering from adverse experiences had a much harder time getting through Katrina. It impacted them to a greater degree, and their ability to rebound from it was quite different. And then more recently, folks have said, you know what, there's actually a fourth realm of ACEs, atrocious cultural experiences. And so I'm going to drop some of those in. So I think we really want to see that ACEs study and our understanding of ACEs continues to grow. And with regard to substance use, there was this really interesting moment of tension after the ACEs study, because folks said, well, wait a second, addiction is biological. We have this medical model of addiction, and we understand that this is about biology. And the ACEs study was saying, but context and environment matters, and that can really ramp up risk. And what we now understand is it is both and, right? It is, yes, there is a medical biological component, and we know that the environment informs the expression and the ability to manage that risk factor. And I think that's a really good example for a lot of the other ways to think, or for how to think about the other elements of risk that the ACEs study and all of the ACEs literature has given us, right? As Hannah said, it doesn't mean that this will happen, but it does mean that we know that there may be factors that we need to really, really lift up to make them less likely to happen. So are we gonna move it? Oh, I know. I see the next question. Sorry.
Right, thank you both for your insightful answers. The next question is, how do positive childhood experiences serve as protective factors that can prevent or mitigate the effect of ACEs?
So I love the concept of positive childhood experiences, and this concept is relatively new, but I like to think of it as, we know that early childhood experiences that are traumatic, they can shape our biology in many negative ways. But the new research is showing that positive childhood experiences can serve as a buffer in many ways to that adversity. There was a study by Bethel and some of her colleagues that identified some positive childhood experiences that have been associated with some really wonderful outcomes and are part of breaking the cycle of trauma. And those 7 paces are the ability to talk with family and about feelings, the sense that family is supportive during difficult times, the enjoyment of participation in community traditions. I think back to my time in Little Springfield, Kentucky, going to the Sorghum Festival every year. Number 4 was feeling a sense of belonging in high school. Number 5, feeling supported by friends. Number 6, having at least 2 non-parental adults who genuinely care. I think about my high school teacher, Miss Rakes, who played such an instrumental role in cultivating resilience in my life. And number 7 is feeling safe and protected by an adult at home. And the research shows that PACEs have positive impacts on mental health, lower depression, anxiety, lower suicidal ideation, as well as impacting physical outcomes, fewer sleep problems, less less risky behaviors, as well as lower substance use behaviors. And then not only that, but there's research that shows PACEs impact psychosocial functioning, lowering stress, reducing loneliness, shame, aggression, and even having a better impact on your body image. And so oftentimes I think we overlook these things, but they are so important and help us become resilient individuals and in many ways serve as buffers against life's greatest adversities.
Yeah, absolutely, Hannah. I think that, before we had the positive childhood experiences published in 2019, anybody who was working in the field knew that even in the face of adversity, even with 4 or more ACEs, which was kind of like that threshold where risk really significantly increased across the board for behavioral health issues, substance use risk, health and well-being kinds of things in the all of the ACEs research. What the positive childhood experience study showed us is what we knew, that not everybody, even with high levels of risk, succumbs to that risk. That's why it's a pyramid. As you go up, the risk gets less at each step. But we didn't always have research to explain the why. Anecdotally and experientially, we all said, well, we know there are certain protective factors and there are things that make people thrive and make them able to be more resilient. And there was some good research out there on that. What the positive childhood experiences study did was use the same methodology as the ACEs study and say, here's the proof. And guess what? One of the outcomes was, even if you have 4 or more ACEs, the more positive experiences you have, the better you report your adult mental health. It cut levels of depression down significantly. So if you have 4 or more ACEs and you only have 1 or 2 positive childhood experiences, over 60% of that group said, I've suffered from depression or poor mental health. But for 4 or more ACEs, the group that said, well, we had a lot of positive experiences, only 21% of them reported that they had experienced depression or poor mental health. That's a huge difference. And that 21%, that's kind of the norm for adults. Those folks didn't look different from the general population. So that was really powerful data to have, and gave us a way to think about, okay, so here's some science, again, to back up what we've been seeing in our clinical practices, in our social service agencies, just in life in general in that way.
Words too. And the next question is, issues around stigma and shame factor into positive and adverse childhood experiences. How is all this connected to stigma and shame related to substance use disorder? And I would like to share a little perspective from my childhood experiences. Growing up in poverty with 2 parents who suffered from drug addiction, or I'm sorry, from substance use disorder. Stigma and shame were constant feelings, the neglect and instability made me feel different from other kids, and it created a sense of isolation and low self-esteem. Positive childhood experiences like the support from my teachers. Shout out to Joan Dubay and Regina Gibson, 2 teachers I will never forget. And other friends and family could sometimes counteract negatively, but the shame of my situation often outweighed those moments. Stigma and shame around my parents' substance use disorder were always present. Family members, judged them, a society judged them as a whole for their problems. And this made it harder to ask for help or to talk to my aunties and uncles or my nana about what was actually going on at home before the state had came in and gained custody of me and then my family. It's like, we want to keep the child out of the foster care system, so they, my dad's side of the family came and stepped in. But as I got older, the fear of being labeled as damaged and troubled because of my upbringing added to my own trauma and soon after substance use disorder. But the connection between childhood experiences and stigma around substance use disorder is clear. Kids like me carry the weight of both their parents' addictions and society's judgments. This stigma makes it harder to heal. Both parents are struggling with their own substance use disorder, and for children dealing with the aftermath, addressing the shame is key to breaking the cycle to trauma and substance use. That's what I'm trying to do now. So I just wanted to share that. Would any of you all like to chime in?
Well, I just want to take a moment to say thank you for being vulnerable and willing to share your story. As a former teacher, I think about the invisible book bag, as I would call it, that often kids pack to school, and we don't always know what those experiences may be. And I know we're going to talk a little bit about trauma-informed care in just a little bit, but I think it's so important that first we acknowledge the role that trauma plays in kids' life, in their development and in their learning, not only in school, but their development outside of school, and then how we're interacting with them in a way that makes them feel safe and secure, knowing that adversity is inevitable, but we can, in many ways, serve as buffers for kids' adversity. I think about, I was reflecting on some of the issues around stigma and shame and how they factor into ACEs. And one thing that came up for me as I was reflecting is generational differences, the way we perceive adversity, and the way we perceive help. We know for a long time that substance use disorder was not categorized as a disease. And so I think it's really important that the general public understands just how trauma and substance use is interrelated and how that impacts how folks behave and how they interact with the world. And Sophie, you are a shining example of resilience and overcoming. And so I commend you for sharing your testimony.
Absolutely. Yes, I agree, Sophie. And I think that, one of the things that's really hard is that stigma, even when we do a good job about talking in community about things, about trying to normalize things, trying to educate, trying to destigmatize, stigma is something that sometimes is carried internally. And that connection to trauma is very powerful because we know that one of the hallmarks of trauma is having a sense of not being in control, a sense of powerlessness. And that often that then connects to feelings of shame, of not being able to change a situation. And then when you load in the feelings of stigma and shame that are often associated with substance use and with addiction and with maybe trying to enter recovery and having varying experiences with that, you see this layering that happens. And I think it can be really powerful. I realized that earlier I had wanted to share a few statistics, but I think that this is a good place to do that. I had done a quick look at the 2024 reports that many of you contributed to, people who are on the call, I think, from the Center on Drug and Alcohol Research at UK, which does a lot of the evaluation work for recovery and substance use treatment across the state. And, so what we see is that in the Kentucky Opioid Replacement Treatment Outcome Study, 86% of people who entered those services reported they had had at least one adverse childhood experience, right? So that's almost everybody who enters. And so that idea that there could be this layering of senses about shame and stigma is very profound. We see that also with moms who are entering some of our specialized treatment programs for moms, where 35% of them are saying that they've had interpersonal victimization in the previous 12 months. So these are really, really powerful intersections that we need to be aware of and pay attention to. And I often use the analogy. There's a wonderful cartoon. Unfortunately, I am not able to drop things in the chat, but maybe I'll send some things to Unshame that they can share out with the participants afterwards. But there's a wonderful cartoon where with Calvin and Hobbes, and Calvin is getting ready for his bath, and he's about to put a rubber ducky in, and he says, and Hobbes says, "Oh, for companionship," because he imagines that having a duck in the bathtub is just a friend. And Calvin says no to test for sharks. And I think that's a really great way to think about this, that if Calvin has only ever had sharks in the bathtub, then even if we tell him over and over again that there are no sharks in the bathtub, why should he believe us? And in fact, I don't want him to believe me because I want him to always be cautious if that's been his life experience. And so we have to balance this idea that unstigmatizing, destigmatizing is going to be a process, and that people have integrated all of their experiences and not having that sense of control. And sometimes that does then make them feel a sense of stigma, rightly or wrongly. It is their feeling, and so that this may take some time. So I appreciate what Unshamed Kentucky does, and I think that when you add in trauma on top of SUD, we just have to remember that there are more layers to get through. And like any onion, as you peel back the layers, sometimes they get stronger as you go more towards the center, and the work gets harder, and that's part of the reality in that way also. Um, so yeah, I think this is a really important piece that sometimes we think we're giving enough attention to it, but I think it's a pretty, pretty deep issue to pay attention to.
Our next question, we are moving into trauma-informed care questions. Our next question is, what do we mean by trauma-informed care, and how can trauma-informed approaches be integrated into the substance use disorder system of care? So we're talking prevention, treatment, and recovery.
Trauma-informed care is really a model that recognizes the impact of trauma on people's well-being, and it aims to prevent re-traumatization. It's based on the understanding that trauma can affect people's neurological, biological, psychological, and social development, and there are some key assumptions within the trauma-informed approach. They like to call them the 4 R's, but those are realization. So realizing the impact of trauma and how trauma impacts families and groups. Recognizing how trauma can manifest itself in behavior. I always like to say behavior is the language of need. Responding, so using principles of the trauma-informed approach, and then the last R being resisting re-traumatization. So thinking about communication, environments, and other factors that can interfere with healing and recovery. And there are 6 key principles within the trauma-informed approach, and I think they offer a great framework to think about the areas of prevention, treatment, and recovery. But those 6 key principles are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. And just one way to think about how you might put that in action when thinking about the principle of safety, not only is that about psychological safety, but it's about physical safety. So if you are offering care, you might think about your seating arrangement in a treatment facility. Folks who have had experiences oftentimes may have problems and challenges of trust. And so the way a seating arrangement can be arranged can provide folks a sense of safety and security. Thinking about trustworthiness and transparency, I think about building rapport. I would say relationships are the foundation of care in many ways. So those are just 2 ways that we can think about that using the principles of trauma-informed care. There's also a lot of great guidance from SAMHSA across the 10 different domains, and it really breaks it down, areas in governance and leadership, policy, physical environment, and others. But I want to give my colleague Miriam a chance to speak to this because I know she has seen a lot of this put into action.
Thank you, Hannah. Absolutely. And I think the examples that you gave are great. I really find that it's that first one, safety, is kind of the foundation that has to be there. So, and we always are paying attention to it, because in the same way that there's a process for maybe gaining trust, there's a process of building safety. And as people do their work, And one of the things that we know is when we're doing both substance use and trauma work simultaneously, we often see that as we go deeper, the work gets harder. So there's a little bit of push pull, right? And there's like some leaning in, and then there's some pulling back, and there's some leaning in and pulling back. And that's normal. And so we're constantly working these 6 elements. We're constantly thinking about what else can I be doing to assure physical and psychological safety, to build up that trust, to make sure that that person knows that I am being transparent. I think transparency becomes a really important piece when we're dealing with people who are engaged with the justice system. And sometimes transparency and being trauma informed in the justice system means saying, I don't know what's going to happen, right? As opposed to not answering or not saying anything, to say, okay, I can tell you that this is the process that you're going to experience. What the outcome is going to be, we don't know yet, right? But let's make sure that we're prepared for the process, and then maybe think about the possible outcomes and the possible choices that you may have. And I do think that those two that are kind of connected, collaboration and mutuality, and then empowerment, voice, and choice, are very, very important, especially in when we're working with substance use disorder with recovery. One of the things that happens in lots of recovery and lots of behavioral health interventions is that when you make the choice to start to work towards wellness, sometimes you have to give things up. And giving things up often means that you no longer have choices, right? It feels sometimes to people like choices being taken away. And I think it's really important that we amplify the opportunities for choice. And they can be very, very small, but they are very powerful. I think anybody who's worked in the field for a long time knows that sometimes if you run into somebody years later, they will tell you that the things that helped them are less about the content and more about the process. And sometimes they'll remember things that you did or said that you wouldn't have even thought of as being, quote unquote, part of your intervention model, but they were powerful. I lived in a very small community in Eastern Kentucky for a long time, so I would often run into people many years later. And I remember running into a young adult who I had seen as a teenager. And one of the things that he said to me was that the reason that he liked coming to my office and he trusted me was because I would let him sit in my desk chair. I didn't care where he sat, right? I had to make sure, obviously, that there was nothing on the desk that would be compromising to anybody else or risk confidentiality. He wanted to sit in my desk chair. That was fine with me. I never would have guessed that it meant that much to him, but he took that and saw it as a sense that I trusted him and that he had some control over the situation. And in his mind, it was huge, which again, I didn't know, but we never do know. And so I think any opportunity for choices, and they have to be both realistic, we have to be able to live with both, is very, very powerful. Where do you want to sit? Or would it be better? Do you not want to sit? Would it be better for you to walk around the room? That's okay too. Do you want the door all the way open, all the way closed, cracked, windows open, closed, or curtains, or like all of these different things? We don't know what somebody's experience has been. We don't know what might be a trauma cue for them, what might make them feel uncomfortable. I think the other thing that we have to remember is, especially again when you're working with persons who are justice involved, is that one of the assumptions of the justice system is that part of how people do better is that they feel ashamed of what they've done that was a violation of society's norms. And that's problematic when you're talking about trauma, because as I said earlier, shame is a very powerful trauma reminder. And so one of the things that we want to really be careful about is to not reinforce shame in our interactions with people, to talk about accountability, to talk about responsibility, to talk about opportunities for change and for doing things differently, but without reinforcing that sense of shame. Because if we do that, we may cause a traumatic stress reaction, which means that somebody is not going to be open either to the relationship or the services or the content of what we're doing in that moment. So trauma-informed care is about what we do, but it's powerfully about how we do everything we do. It's not separate from any other intervention. It is embedded into the way we deliver all of those interventions. And I do want to say that I think that when you look at the way you do things, my suspicion is that you already do a lot that is trauma informed in the work that you do, and that there are opportunities to be more intentional about doing some of those things. But when I think about lots of other programs out there in the world, when we're thinking about kids and we're thinking about, for example, our family resource centers or our Kentucky Strengthening Families programs, they're the tenets of both of those frameworks is very aligned with being trauma informed and being resilience building. We know that there are some particular interventions that address co-occurring trauma and substance use, things like seeking safety and some other interventions. I will tell you that the research is limited, and sometimes the research is a little bit discouraging because sometimes what we see is that the actual intervention may not make as much of a difference as we would hope. What I will say is that what we see from the research is that being trauma informed in the way we do things and building those trusting relationships and connecting with people and meeting them where they are, those are all powerful. And one of the other, you can tell I get a little excited about this, sorry. But one of the other things that I do want to lift up is that the third principle of being trauma informed, which is peer support. And the substance use and recovery world has understood the power of peer support and lived experience and mutual support in a way that many other parts of the behavioral health and social service world has not. And so I really want to give you kudos and thank you for helping the rest of us to understand this a little bit more. But there is nothing that we can say that can lessen that, like the power of that relationship and the power that comes from not only being a recipient of peer support, but then also being able to be mutual in that relationship and offer it to others. And we know that the empowerment that comes from that experience is unparalleled. And so every time you're doing those things, that is part of being trauma informed in the work that you're doing. And again, the question always is, okay, we are doing this, and how can we do it even more or better? And I think that we can all always continue to evolve and use these 6 principles. I do want to add that there's some a nice parallel to the 4 R's that Hannah mentioned of realizing, recognizing, responding, and resisting re-traumatization. And these are 4 I's that can help to build resilience, which is identifying strengths, inoculating people against risk, so helping them figure out what is protective for them, instilling a sense of hope, and improving their access to those resources, both internally and externally. So this is evolving. I just want to give a nod to one of the things I didn't mention when we were talking about the explosion following the ACEs study is the framework of being healing centered, right? And I think, again, that's something that the recovery models are inherently healing centered. When healing centered engagement came out, it was a response to young kids, young adults, transition age youth saying to Sean Gin Wright in California, "We are more than our trauma. Don't define us by our trauma. Part of our healing is we want to access our whole selves and build that up." And I think that's inherent to recovery as well. And that, so that again, the parallels, I don't think it's a big stretch for substance use treatment and recovery services to be trauma informed. It may just be a matter of really being intentional about thinking it through. So, sorry, a lot there.
Our next question is, how can we ensure that these trauma-informed approaches are culturally appropriate and tailored to the needs of diverse populations? And I believe to ensure culturally appropriate and tailored care, trauma-informed approaches must consider the unique experiences of different populations. For example, Other marginalized groups may face additional layers of trauma due to systematic racism, poverty, or lack of access to resources. Providers should be trained in cultural humility and work to understand the specific cultural and historical traumas that may influence their patients' lives. By involving community voices and offering services that respect cultural differences, trauma-informed care can be adapted to meet the diverse needs of all individuals in the substance use disorder system.
I couldn't agree more, Sophie. I think building on strengths of individuals and communities is a key component. There was actually a study done in 2021 that examined the health paradox of many Latino families, and they discussed how these unique experiences within this population make them particularly vulnerable at times to ACEs, but also that they have unique cultural protective factors that could also serve as a buffer. And so there is a need for more research, more data to be done, but it's so important to make sure that we recognize these cultural differences, but also acknowledge the strengths that come with many of those diverse populations.
Yeah, absolutely. I think this is a really complex issue. And again, something that we're understanding the complexity more and more over time. And so this idea of cultural humility, of understanding that people are the experts about themselves. So, again, elevating lived experience, but taking that to a community level, to a cultural level, to say, I don't know what makes sense for you, but let's work on this together. And really being good active listeners and observers, I think is critical. I think our language really matters. And one of the things that has happened is, for many years I would fuss about the fact that trauma was being overused. People sometimes were conflating trauma and drama. And, we had to be really careful about what we called trauma and traumatic. And we know that it's a personal experience and we don't want to overuse it. And I think in recent years, I've had the same feeling about the term resilience. And there's actually been some pushback from communities, Black and Brown communities in particular, around the use of the term resilience and the application of the term. And I think it's really, really important for us to talk about the fact that, number one, resilience is not heritable. Isn't something that you're born with or not. It also is, it comes and goes for everybody at different times, in different contexts. We may be more or less resilient, but most importantly, we never want to expect that people are to be resilient when they are in a place of systemic or structural oppression or discrimination or racism of any kind. And that's an inappropriate use of that term. And I think that we have to be sensitive and we have to talk to people about what are the words that make sense for you, that you're comfortable with. I was a white Jewish New Yorker who moved to Appalachian, Kentucky. And so I did a lot of learning from my colleagues, from my clients and patients, and from the community about what language was best, what phrasing, what tone of voice. I would speak loud and fast. I still sometimes do, but I really had to learn about that. And I think we all have to, but particularly we have to be careful that when we're paying attention to the 6 principles of being trauma informed or the 4 R's, we don't also forget about those equity and culturally humble ways of doing our work. And we don't get a pass for that, even though equity issues are one of the 6 principles. So, it's a constant self-reflection. I think this work is really hard. It touches us in profound ways. There's probably a whole other seminar on professional well-being and resilience. But as part of that, what we know is that it's also really important to get peer support for us as providers, as helpers in this world. And that's a place where sometimes we can check ourselves and we can talk about, I'm not sure how to approach this, or I said something and I think maybe I I made a mistake, that I did something that was culturally not responsive, not appropriate. How am I going to fix that? And we really have to be honest with ourselves and work that through and take ownership of it. What a beautiful model of how we can all be in this world if we can do that in these relationships and in these services in that way. So I think it's important and it's complicated. Anyway, I think that's what I have to say.
Thank you so much. So now we will be moving into tools. What are best practices for how some service providers should identify and address the impact of ACEs and PACEs for individuals, families, and communities addressing substance use disorder or opioid use disorder?
I can hop in. And Miriam, I always love listening to you. I always feel like I gain more nuance, more understanding, and greater clarity. So thank you for sharing your depth and expertise. Thinking about best practices, I think one of the best ways to help folks is to make sure that your staff is trained and understands not only what ACEs are, but what does trauma-informed care mean and what does that look like in practice. There's a wonderful coalition called the Bounce Coalition that is dedicated to building resiliency in children, adults, and families, and they do that in a variety of ways by providing trainings and evaluative services, as well as advocating for different policies that support folks that have experienced trauma, as well as thinking about preventing trauma. That organization, they also host resilience screenings and oftentimes have a wonderful dialogue. Actually, I am a member of the Bounce Coalition, and we're going to be hosting a resilience screening in the next month, where we're going to be showing the documentary on resilience, the biology of hope and stress, and we're going to be having a panel conversation with a community. So it's not just going to be a school that we're necessarily working with or a particular organization, but we are working with a community to better understand ACEs, better understand trauma, and how everyone can get involved in this work. Miriam mentioned the healing-centered framework. There's a lot of wonderful frameworks out there. Another great one is the Strengthening Families framework, and I know Miriam can speak more to that, but many of these frameworks can help build the foundation and understanding for how we can incorporate these practices within not only our schools, our organizations, but our communities as a whole.
Absolutely. And I think that, one of the things to remember is that sometimes something sounds like it's maybe for child providers, right? But something like Kentucky Strengthening Families really is for everybody in the family. I would point to a couple of other resources that maybe Saskia can drop in. Thank you for dropping them in. I see you in the document. One is that we've started something in Kentucky called Partnership for Resilient Kentucky. And this is an opportunity to spread research and best practices and some examples of ways that positive childhood experiences are being implemented into programming and services here in Kentucky and elsewhere. It's a free organization. It really is just to enhance knowledge and create networks and communities. And we have 2 virtual meetings a year, but there's a lot of resources on that website that are culled from both the research literature and other resources. So that can be a resource place. Another national organization is something called HOPE, Healthy Outcomes from Positive Experiences. And HOPE emerged at Tufts University after the Positive Childhood Experiences study, and is a way of organizing what we understand from the literature and the evidence around the building blocks of positive experiences. Again, often uses families as the center point, but for everybody and across the lifespan. And I find that that HOPE is a very helpful resource in that way. But I think that regardless of what intervention you're doing and what model you're doing, one of the most basic tools is to approach the world, and particularly your work in the recovery space and in substance use disorder, with the assumption that when people come into our realm, into our programs and services, that we have to assume that they're coming with good intentions, that they're coming, and at that moment, they are making the best choice for themselves in that moment. If they made the decision 5 hours later, or maybe even 5 minutes later, they might make a different decision. But in that moment, however they're acting is on some level, whether it's reactive or thoughtful, what seems to be the best choice for their brain and body at that moment. And sometimes that's hard because sometimes people's responses are not what we want them to be, or not what we hope they will be, or aren't very nice to us. And it's our job to say what is going on for this person that makes that the best choice for them in this moment. And how can I help them find other options and maybe make a different choice in the next moment, or something that could be more helpful, supportive, or help me help them in some way. And I think if we can just have that paradigm, always have that question of, or that assumption that however somebody is reacting, acting, responding, is what is making sense for them in that moment, then we can go in from a place of curiosity and openness and compassion and willingness to help and meet them where they are. I think that's really a big piece of this, and it makes putting all of these other frameworks and all of these other interventions into place so much easier and so much more natural. I mean, they kind of flow then at that point in that way. I did mention, a specific seeking safety is one family. There's also another one, and I can't remember the exact name, is specifically for men who are both incarcerated and have trauma and have substance use. So there are some nice frameworks out there. We know that cognitive behavioral approaches can be very successful. And we know that we have to meet people where they are. And we also know that things like EMDR can be very helpful in helping people manage their trauma and then be more able to access their recovery supports. So a lot of times it's quilting things together and not being afraid to do things simultaneously in that way. So I think that I'm just looking at my notes and to see, okay, here we are.
How can we reduce the stigma associated with both ACEs and opioid use disorder to improve access to care and promote better outcomes?
I can jump in. So I think, Miriam talked a little bit about the HOPE framework, healthy outcomes from positive experiences. And I think just highlighting stories of hope. Today, Sophie has shared some of her experiences, and I don't know about you all, but I'm leaving with a sense of hope and optimism, knowing that despite the challenges that Sophie has endured, despite the challenges that Miriam, myself, and many others have endured, at times because of resilience, we've been able to overcome and push through. And so I'm a big believer in public education campaigns. I'm a believer that education, giving people the tools to name and understand not only their previous experiences, but how it's impacted them. And then also making some of those connections really clear. Sharing those stories of hope, talking about challenges and how that's impacted us and how it has directed us in new ways, as well as thinking about policy, which I think is a key component. We are seeing nationally a lot of I'll say attacks, for lack of a better word, against trauma-informed care. And we know how important trauma-informed care is in supporting individuals. So continuing to further the message that trauma-informed care is important, and it further helps people on their journey of healing and recovery. And then also supporting policies that help greater access to treatment. We've seen policies over the years that create greater access to tools. I think a lot about harm reduction as well in this piece. And communicating the research about those practices. So those are some of my suggestions on reducing stigma. And then the last pillar, I guess, would be focusing on strengths. I'm a big believer that every single person, each of us, we have something that is special, that is unique. There's a strength within us that we can use to help change our life in many ways.
Yeah, absolutely. Hannah, thank you. I think that was beautifully said. And I think that we have to be what we want to see, right, in the world, and we have to model by example. And so our small gestures, the way we treat one another, the way we choose to live our values is really important. And so I think it's not just about what we do in that formal setting. It's not just when we shut the door and we're in a an intervention moment, but it's everything else. It's and this is part of that tenet of being trauma informed, but it's being welcoming when people are answering the phone, when we're what our websites look like, what our physical spaces look like, how we position ourselves in the community, how we represent ourselves as an organization in the community, how engaged we are in the community, right? Green space and playgrounds and garbage pickup and access to clean water and clean air. That's everybody's business. Like, we should all be paying attention to all of this. So I think it becomes a very holistic approach, and that as we normalize that we are all struggling with different things, and we promote what is positive, and we work together to improve lots of things about communities, both for individuals and families and for communities, that is powerful. I will say, from like a concrete practical strategy, we should always be paying attention to our language. I didn't say this earlier, but one of the assumptions of trauma-informed care is using person-first language and treating people with respect at every moment. So I think that's probably a given, but I did want to just say it for the record. So Sophie, thank you so much.
All for everything that y'all have. I've learned a lot from you all as well. I'm on my like learning curve. I'm kind of new to this world and everything, and as I'm finishing my studies and gaining my professional footing, I'm learning different things, and this has been a learning experience. And right now, I may only have uh lived experience to give to the conversation, but like I said, I am learning and growing every day, and I'm happy to be where I am. As Ms. Hannah said earlier, our past do not define us. The experience in my childhood, I used to use as a crutch to further fuel my substance use disorder, my opioid use disorder, but now I use them as learning experiences of how one day I don't want to treat, my children, or as I grow into my social worker role, how to spot, you know, I'm how to spot, adverse childhood experiences, and I want to lead with trauma-informed care. So thank you all so much.
Thank you, Sophie. And I want to encourage you to value that lived experience. It's never only your lived experience. It's your lived experience is a powerful place for you to be starting from.
Thank you so much to our amazing speakers today. Again, let's give them a digital round of applause. Thank you all for bringing forth and explaining your expertises, your experiences, and also just being transparent. This was an amazing conversation. So I just dropped in the chat for everyone. So there are many ways to get involved with our campaign. We're always interested in looking for new partners, community partners, individuals who are interested in sharing their stories and their lived experience, and also just having the conversations. I've also dropped my email in the chat as well. So if anyone has any questions regarding our Unchained Kentucky campaign, please feel free to reach out to me. We're always open to having the conversations. So we want to thank you all so much for joining us on our webinar today. We want you all to have an amazing day and have an amazing weekend. Thank you, everyone.